Hi, my name is Ana Morales, and I am going to talk about heparin-induced thrombocytopenias presenting as bilateral adrenal hemorrhages. Definitions. Heparin-induced thrombocytopenias is an autoimmune complication that is caused by the presence of heparin-dependent antibodies. Classically, patients with heparin-induced thrombocytopenias present absolute thrombocytopenias or a relative decrease in the number of platelets, which is related to the appearance of thrombotic phenomenon, and this implies the immediate expansion of heparin. The treatment of complication and the appropriate choice of the alternative therapeutic when it's necessary to continue anticoagulation.
The term heparin-induced thrombocytopenia can be divided into two parts. Heparin refers to an anticoagulant medication which prevents blood clots from forming, and thrombocytopenia refers to decreased number of thrombocytes or platelets in the blood. So, heparin-induced thrombocytopenia, or HIT, is a complication caused by heparin that results in decreased platelets in the blood. Okay, so imagine you're making dinner and accidentally cut one of your fingers. Now, if your body doesn't stop the bleeding, you'll keep losing blood until there's not enough to supply the vital organs like the heart and brain. Now, to prevent this from happening, the body has a process called hemostasis. This process has two phases, primary and secondary hemostasis. In primary hemostasis, platelets aggregate to form a plug at the site of an injured blood vessel. While these platelets are aggregating, coagulation or secondary hemostasis starts.
Applications in medicine. The incidence of heparin-induced thrombocytopenias is particularly high in patients receiving heart transplants, 11%, and those undergoing orthopedic surgery, and it's generally higher in surgical patients than in those receiving medical treatment. Heparin-induced thrombocytopenias is rare in pediatric and obstetric patients, and in patients receiving hemodialysis. However, we should remember that despite the large variability in the incidence, patients of any age with any condition and receiving any type of heparin at any dose and via any administration route can develop heparin-induced thrombocytopenias.
Of all the patients you see, only 5% are likely to develop HIT who have a prolonged exposure to heparin. An important point to note is that your patients on unfractionated heparin have a higher risk of developing HIT than if they're on low molecular weight heparin. Risk factors for immune-mediated heparin-induced thrombocytopenia include a long duration of exposure to heparin, exposure to unfractionated heparin, being female, and a history of recent surgery. So let's discuss the physiology of HIT. Platelets have a receptor called platelet factor 4 bound to their outer surfaces. When heparin is introduced into the bloodstream, the heparin binds the platelet factor 4 receptor. Generally, if a patient had a previous exposure to heparin, they may have developed an anti-heparin platelet factor complex antibody. This antibody binds the heparin platelet factor complex. The heparin PFR or platelet factor receptor antibody, when bound to its target, can activate other platelets. So the activation of platelets can lead to thrombi or clot formation, as well as consumption of these platelets by the body. Now that we've gone over the physiology, let's talk about how to diagnose heparin-induced thrombocytopenia type 2. If a patient with a current exposure to heparin has a 50% drop in their platelets after 5 to 10 days of exposure, this would indicate this patient likely has HIT. Now keep in mind this time frame may be shorter if they had a previous known exposure to heparin. Other important findings that are indicative of HIT is if your patient develops a reaction to heparin. These reactions to heparin include necrotic skin lesions, tachycardia, dyspnea or difficulty breathing, chills, and fevers. Remember that patients with HIT are hypercoagulable, so thrombi can develop. Thrombi include DVTs, PEs, otherwise known as pulmonary embolisms, limb gangrene due to arterial thrombi, and finally, cerebral sinus thrombosis. The serotonin release assay is the gold standard for diagnosis of HIT type 2. The way the serotonin release assay works is that you take your patient's serum, who you suspect has HIT, and mix it with platelets that have a radio-labeled 14-carbon serotonin. When these platelets are activated, they release the serotonin with a 14-carbon radiolabel. The radiolabeled platelets are mixed with your patient's serum, and the combination exposed to heparin. If your patient has HIT, the heparin will lead to activation of platelets and release of the 14-carbon serotonin. If the radiolabeled 14-carbon serotonin is detected, then you have a positive serotonin assay for HIT type 2. Another test used to detect HIT type 2 is the platelet aggregation assay. In this assay, we take normal platelets and mix them with the serum of your patient with suspected HIT. We then introduce different doses of heparin into 3 samples. If the patient has HIT, then at low levels and at therapeutic levels, there will be low aggregation and high aggregation respectively. At high doses, no aggregation occurs as the heparin PF4 antibodies become overwhelmed. Now that we've discussed how to diagnose HIT type 2, we will discuss treatment.
Pros and cons. Pros. Heparin-induced thrombocytopenias can be detected early in patients receiving heparin by monitoring the platelet count. Demonstration of heparin-dependent platelet activation using an antigen or functional acid confirms the clinical diagnosis. Once the diagnosis of heparin-induced thrombocytopenia has been confirmed serologically, or there is a high level of suspicion of heparin-induced thrombocytopenias, heparin must be suspended and treatment with an alternative anticoagulant should be considered. Cons. The complications of this pathology are thromboembolic phenomena that entail high morbidity and mortality, up to 9 and 11%, required amputation of the legs, and mortality reaches 8 and 20% despite treatment. From the cardiological point of view, thrombotic complications such as occlusion of venous graft, venous thrombosis in patients with central catheter, formation of atrial and ventricular thrombosis, post-septic thrombosis, myocardial infection, and pulmonary embolism have been described.
So what are some of the clinical features of HIT type 2? This is actually the one that we talk about in the clinical setting. We do see venous and arterial thromboses, so both clots in the veins and the arteries. And it's not insignificant. Actually, up to half of HIT cases will have clots or thromboses. So with regards to venous thromboses, we see deep vein thrombosis and pulmonary embolism. So you may see a asymmetric lag. So this lag here has a deep vein thrombosis. You can also see arterial thromboses. These can be devastating. You may have a myocardial infarction, so a heart attack. You may have a stroke. So again, these can be devastating. We don't see this with HIT type 1. We see it with HIT type 2 because of the activation of the coagulation cascade. We can also see heparin-induced skin necrosis. It can look something like this. This seems to occur more likely when we're using low molecular weight heparin as opposed to unfractionated heparin. And you can also see signs and symptoms of thrombocytopenia. This is a thrombocytopenia, so you can see signs and symptoms of a low platelet count. So things like mucosal bleeding, so bleeding around the gums, bleeding from the skin. You can see epistaxis, so a bloody nose. You can see easy bruising. And you can see petechiae, purpura, and ecchymoses.
Issues applied in Ecuador. In Ecuador, heparin-induced thrombocytopenias has been described in patients treated with all types of heparins and at any dose, included causes of patients with heparin-coated catheters and patients treated with small boluses of 216 units of heparin. The incidence of heparin-induced thrombocytopenias is up to 10 times higher in patients treated with intravenous heparin than in those treated with low molecular weight heparin. An increasing incidence of heparin-induced thrombocytopenias has also been described in patients treated with heparin within 100 days of re-procedures. Conclusions: heparin-induced thrombocytopenias is a severe complication of a very common treatment. It is underdiagnosed and should be suspended in all patients treated with heparin who display thrombocytopenias or thrombosis. Other common causes of thrombocytopenia should be ruled out prior to the diagnosis of heparin-induced thrombocytopenias. When there is clinical suspicion of heparin-induced thrombocytopenias, treatment with heparin should be immediately discontinued, and alternative anticoagulants such as direct thrombase inhibitors or heparinoids evaluated. 10.